Hello, everyone. Uh, it's a great honor to have all of you here to attend this wonderful session. The title is Minimized and Zero Fluoro Evaluation Tricks and Tips. Uh, I'm Dr. Jiang from Sovereign Hospital, Zhejiang University, and it's my honor to introduce my Japanese colleague, Dr. Kanosuke Yamashita, as a co-modulator. He is from Senda Kosi Hospital. Sorry,
Thank you.
yeah, correct for me. So,
Yeah, that's fine. Thank you.
yeah. And he also will serve as a fourth speaker. And today I'm very happy. We have three other presenters, speakers. Dr. Qian Pian Chen from Australia, and Dr. Jiang Ru Hong from Sovereign Hospital. And so uh, let me introduce this. Let's start the first presentation first. Uh, let's welcome Dr. Kanasuki Yamashita. He
Yeah.
will talk about zero fluoro ablation tips with the two circular PFA catheters. So, Dr. Kanasuki
Okay.
Yamashita.
Yeah. And thank you, Jen. My name is Kenosuke Yamashita from Sendai Kosei Hospital, Japan. Okay. Let's share my slide. Can you see this slide?
Yes, very
Okay.
well.
Okay. Hello, everyone. Thank you for joining today. I'm going to talk about some clinical tips for performing zero fluoroscopy ablation using two different types of circular PFA catheter. Okay. Here's my COI slide. Today's agenda is divided into three main parts. First is era of PFA. In Japan, we started using PFA in clinical practice from September 2024. Since then, what's actually changed in our ablation procedures? As you know, there are clearly many benefits. Shorter procedure time, improved clinical outcomes. That was showed in single shot champion trial, and a lower rate of complications like chronic nerve injury, stroke, and esophageal injury. But we also face some new challenges. For me, there are three main issues. First, longer fluoroscopy time. Second, difficulty in accessing catheter contact and creating regions like we can with RFA catheter. And third, challenges in teaching junior operators. This meta-analysis shows that compared to thermal ablation, PFA shortens procedure time, but increases fluoroscopy time. That's a real concern for our own radiation exposures. Another issue is unintentional left atrial appendage isolation or posterior wall isolation, which can increase the risk of atrial tachycardia and stroke. And that's a big problem. This data from FARAPARTS shows that even with 3D mapping, outcomes didn't improve, but the procedure time increased and left atrial dwell time increased. So the added value of 3D mapping may be limited in PFA catheter. Here's an image of FARAPARTS and a CARTO, ICE, and fluoroscopy. As you can see, even when deployed, it's hard to judge basket shape or flower shapes using 3D alone. We can differentiate basket or flower in 3D mapping only. So how about using a cycle mapping cluster instead? Bypass or parcel to cluster? As you know, bypass is integrated with the card system, so its positional information is highly accurate. Even with parcel, which is based on impedance, the cluster position can still be visualized clearly in 3D mapping, as you can see, and compared to fluoroscopic images. You can localize the cluster using 3D alone, and even subtle differences between electrode 1 and 9 are well represented in the 3D mapping. This is our workflow. We use general anesthesia and insert on IGEL for airway management, and ventilation is fully controlled. We only use two venous punctures, both from the right femoral vein, one for eyes and the other for the PFSCs. Accurate femoral puncture is essential. We always use ultrasound guidance, never rely on experience alone. Then we advance the Cs to the SBC, visualize the fossa ovalis with eyes, and perform transeptal puncture using a Bata-Cross RF wire. It's a really easy way. Now let's talk about how to recognize cluster contact. This is from data like IMPULSE, PEFCAT, and PEFCAT2, which all shows that ICE is critical for ensuring durable PVI by confirming cluster contact. Here's a case from our hospital using parcel to cluster for an inferior common PV. ICE clearly shows the cluster touching the PV ostium. This is a big advantage. The procedure time is about 53 minutes and fluoroscopy time less than 0.1 minutes. For bypass, the tissue proximity indication (TPI) feature in card helps assess contact. If impedance increases by more than 7% compared to the blood pool, the cluster is in contact. This is an objective and reproducible method. So from here, all we need to do is perform the PVI while keeping an eye on the TPS signal. But there's a key question. What's the difference between these two region sets? The answer is just because two tags are close together doesn't mean they are connected. If the tags were created in the same application like that, then the area between them is well operated. But if they come from different applications, even if they are close, the tissue in between might still be viable. So we need to be very careful with that. But what's about Perfect? It has a unique design with a 20-degree forward bend. Contact is indicated when this forward bend visually rebounds. Electrode 5 is at the top, so making sure that electrode is in contact is key. Another way to assess contact is using NSI's near-field technology, like the PPAP map reported by Dr. Nishiuchi in Japan. If the bipolar electrogram shows higher frequency, it indicates contact, stable contact, and beta contact. So combining anatomical and electronical information is very important. If you rely only on anatomy, contact can only be judged by the bending of electrode 5, like that. This upper image shows improper contact. It's essential to ensure the cluster is rebounding, not just leaning forward. Here's a video from a case on the left superior ridge, Kumajin ridge. The LSPV is quite dilated at 28 mm, and we are trying to contact the ridge. just anterior to the LSPB. We anchor the wire in the LSPB and direct electrode 5 around 3 o'clock towards the ledge. In this case, application is about 40 application in LSPB. Next, this slide shows contact at the anterior side of the RSPB again. Electrode 5 needs to rebound to ensure contact, like that. To achieve this, the transceptor puncture site should be a bit anterior to maintain space from the right pulmonary veins. Here's a video showing how we rotate the catheter clockwise with the bend neutralized to ensure proper contact and effective lesion creation. So we need to contact anterior side. Next, how to utilize the 3D mapping. With bypass catheter, since it's integrated with card system, so we insert the catheter into the left atrial appendage first and take a snapshot first to avoid accidental left atrial appendage isolation. Then, as long as we watch the TPI information, we can proceed with PBI safety. If a TPI doesn't shine, the catheter is not in contact, so we skip that application. We avoid applying energy to non-contact sites whenever possible. Since paracel catheter has an overdue wire design, it's important to visualize the shape of the wire. With the NSAT system, you can display the wire in 3D simply for connecting it with the alligator clips like that. On the other hand, with card system, prior registration is required. At our center, we pre-register the wire as a 2 French catheter with 1 mm electrode size and 5 mm spacing. This allows us to guide the wire in the PB branches using 3D guidance alone. Here's the actual 3D image. Upper side is NSAT system and lower is card system. Although eyes gives us some idea of wire position, only 3D can show exactly which PV branches the wire is in. To insert the paracel cuts in the left superior pulmonary vein, we keep the seats relatively straight and just advance the catheter gently under eyes and 3D guidance like that. As you can see, the wire and paracel catheter in the anterior side, we pull the wire and clock the rotation catheter and push the catheter straight. To move from left superior pulmonary vein to left inferior pulmonary vein, we pull the wire to the catheter chip, pull the catheter back to the center of the left atrium, bend the Cs towards 5 to 6 o'clock, and rewire into LIPB. Eyes often shows the LIPB clearly too. For right superior pulmonary vein, we pull back from the left inferior pulmonary vein, extend the Cs deflection, and rotate clockwise, usually pointing the catheter around 10 to 11 o'clock. Finally, for right inferior pulmonary vein, just like LIPB, pull the wire to the tip, bend the Cs to around 6 to 7 o'clock, and the catheter naturally enters LIPB. Eyes works well here too. One thing to note, bypass has magnetic sensor, 3 magnetic sensor, but Parselector doesn't have magnetic sensor. It uses impedance-based tracking only. So position error is plus minus 3 mm. Here's the voltage map after one bypass application. The region tag and the area of low voltage area align well. On the other hand, but with Parselector, the snapshot position and actual voltage drops don't always match like that. We need to recognize this limitation. So this slide shows the region tags and the post voltage map. There's some mismatch. So in our center, we always keep about 20 millimeter between the left and right isolation lines to prevent unintended connection. There are data from 20 consecutive cases we are currently revising. All procedures use the same workflow. Average procedure time was 48 minutes skin to skin. Fluoroscopy time was 0.0 minutes, only for univocal capture. And radiation dose was just 0.04 milligram. I think it's very acceptable numbers. And this is my conclusion. By combining IS-guided transceptor puncture with either TPA-guided body parts or current-guided part set, we can clearly visualize custom movement and achieve zero fluoroscopy ablation. Thank you very much for your attention.
Thank you very much, Dr. Yamashita. Zero fluoro ablation for AF using pulse PFA. You mentioned the three different catheters. One is Faro pulse, and the second one is pulse select and Varipulse. And with the 3D mapping system, mainly it's a Cato 3, right?
Yeah,
Yeah,
exactly. Yeah,
and
we mainly use CAR3
yes,
system.
it's amazing. Use the same as 3D mapping system, you can make all these catheters visible in the 3D mapping system and can see X-ray exposure. And actually, you minimize X-ray to zero,
Yeah,
zero. So it's
yeah.
wonderful. So
Thank you.
maybe we can discuss at the end of the lecture, please. And
Okay.
so let's move to next talk. So please, you moderate.
Okay. Next speaker is Dr. Ruhon Jiang from South Hospital. Yeah. The title is Non-Fluoro Ablation with Ice Guidance. And Dr. Jiang, please
Yeah,
talk about it.
yeah, thank you. So, can you see my slides?
Yes,
Yeah?
yes.
Okay, okay. Good afternoon, everyone.
Okay.
I am Dr. Lu Hongjiang from Seoul Hospital, Zhejiang University School of Medicine. So, today it's a great opportunity to share our experience in performing non-fluoro AFib vibration with ice guidance. And this is my closure. I have no relevant financial disclosures. Currently, China faces a very critical public health challenge with over 20 million of AFib patients, and annually about zero point 0.7 million new AFib cases increased. So with aging populations, and it is estimated about zero point 0.8 to zero point 0.7 to zero point 0.8 million new cases will occur annually. So uh, the treatment for the AFib cases is very heavy. And this is the pictures taken months before. This is our lab, and this floor is our catheter labs. At the midnight, only us was still working at the midnight, and the physician is so tired to go to sleep. Also, in the 2021, we published a paper in the International Journal International Journal of Cardiology. We found that more than 67% of the interventional cardiologist has body pain compared to the 25% in the non-interventional cardiologist. And the main location is the head, is the neck, shoulder, and the back. So due to the heavy the protection equipment, the lead apron, we need to use the lead apron to protect So the non-fluoro technology directly addresses occupational hazard. And the field of the catheter therapy for the cardiac arrhythmia has been remarkably advancement in the 1920 and in the 1980s. The IFCA was introduced to treatment for the treatment of the tachyarrhythmias and with the technology advancement, mainly including the 3D mapping systems and the ICE technologies, now we can perform the totally non-fluoro technology to do the EP procedures. And all these advancements align with Aurora principles, and we're aiming to minimize radiation exposure while maintaining the procedure the efficacy and the safety. The non-fluoro cardiac EP lab offers several key advantages. First, it can eliminate the X-ray, which is important for special populations such as pregnant women and children. And second, it can reduces cumulative harm of the radiations to the medical staffs, and it also relieves the occupational damage caused by the long-term wearing of the protective equipment. And last, it also reduces the cost of the DAC equipment, and it reduces the scheduling conflicts with the other interventional procedures. This is non-fluoro EP procedures performed in our surgical operation rooms. We can see every staff, including the operator, the nurse, and the cis. We do not need to wear the lead apron, and the working sense is very relaxed. Our working platform for the non-fluoro AFib ablation relies heavily on the ICE catheter. ICE provides us a real-time visualization of the cardiac structures, and we also combine this technology with 3D mapping systems, including the ultrasound, and to enhance the procedure accuracy and safety. At our hospital, we have developed a comprehensive non-fluoro AFib ablation workflow. The key steps include the RV mapping, thrombus detections. We do the non-fluoro septal punctures, and then we do the ultrasound to get the ALA geometries and do the FAM with the multiple electrode catheters. And then we do the bilateral PVIs, and also we do some additional ablations, use contact force sensing catheters, and in the whole procedure times, we monitor the complications. And for AFib procedures, mainly we need to have 1 to 2 hours to finish the job. These are several key views. We use the ICE fans, several key fans of the ICE, which we get to construct the AOA geometries. First, when we place the ICE catheter in the right side atriums, we get the home view to locate the transcatheter annual and the RV. Then we rotate the catheter crosswisely. We can get the AOA view outlines and the left atrial appendage. Also, sometimes we can mark the CS ostiums. Then we rotate the crosswisely, and we can see the view of the left side PVs, ALSPV, ALIPVs. We put a point to locate the outcomes. And then we go to the left posterior wall of the AOA, and we also can see the location of the esophagus. We make a geometry of the esophagus to avoid too much energy when during the ablation. And the last view in the LA is the view of have the ISPV and RIPV. Then we put the ice catheter into the right side ventricle and rotate clockwise. We can get the view of the ridge. We can see the LAA, LSPV, and LA, and we get several views to build geometry. After that, we will do the non-fluoro transeptal punctures. This is a very key step for the non-fluoro AFib ablation. Firstly, we get the LPV fans, and we get the P-tight until showing the aortic root, and then we get the R fractions to find the SVC. So we find the SVC views, and then we insert the long wire into the SVC and followed by the launches, which is very safe. And then we pull back the launches and with the wire, with the J wire outside, we will get the ideal puncture side. And we use the electrode coagulation energy to do the punctures. And after we get a successful puncture, and the launch will followed by the wire, and it's very easy. After the non-fluoro transeptal punctures, we use the lateral catheter or pantry catheter to have the to do the fan to get the geometry of the LPVs, right PVs, and use the fusion function with the sound model. This is the workflow of our non-fluoro AFib ablation procedures in Solar hospitals. In patients using the RF energy, the assistant will help to track the tips of the ablation catheters to make sure the ablation site is very accuracy. And this is a right inferior ablation, right inferior PVs. And this is when we do the ablation targeting the ridge. Also, in the age of the PFA, we use the non-fluoro technology to make sure the contact is enough, and also, as the professor showed before, we use the ice catheter to guide every type of the PFA catheters. And when we do a lot of the non-fluoro cases, we find the ice is very useful, including detecting the thrombus, like the instrument thrombus, when the heparin is not enough. So we not give the enough heparin at the very beginning after the vein puncture. And we also can find the very early stage of the cardiac effusion and or the cardiac tamponade, which makes the procedure much safer. And this is a history of our hospital for the non-fluoro EP procedures. In the 2019 to 2090, we performed over 1,000 procedures without X-ray in the traditional DSA rooms. We get the experience, and then in 4 years before, we tried to do the non-fluoro EP procedures in the surgical operating rooms. We have no equipment. We have no equipment with X-ray, and over 200 cases were done. And in the last year, we built our own non-fluoro EP lab just nearby the traditional DSA labs. We can see in this room there's no DSA equipment. We can get big screens and have the only a table for a bed for the patient, 3D mapping systems, and IC equipment. And we have no conflict in the scheduling of the procedures. Also, the training and the assessment are very critical for the successful improvements of the non-fluoro catheter ablations. Based on our CHIs, we offer comprehensive training programs for physicians and nurses, and to ensuring they are very equipmented with necessary skills, knowledge, and tools. And we also do the certifications. Certification through the cardiac EP trainings assessments for the sports standardization and the quality of the procedures. And in 2026, the Chinese export consensus on the construction of the fluorless cardiac EP lab and related techniques were published. This statement is the results and the results are experienced of the leading experts in the field in China, when aiming to standardize the practices and promote the adoption of the non-fluoro technologies in the nationwide. And today, there are over about 80 centers across the countries was built with non-fluoro EP labs, and the adoption of this technology is growing very rapidly, and also this trend reflects the increasing recognition of the benefits of the fluorless technology also for the patient and for the medical staffs. This year's slides I show you today. Thank you very much.
Thanks to Dr. Chen. Dr. Chen provided an excellent overview of a workflow that fully utilized ICE. I was particularly impressed to see how ICE was effectively used, not only for RFA but also for PFA, similar to our approach for confirming catheter tissue contact. In Japan, EP rooms without fluoroscopy equipment are virtually unheard of, so the images you shared were truly eye-opening. We are now inspired to move toward creating a fluoroscopy-free EP lab ourselves. Thank you, Dr. Jen.
Thank you.
Thank you very much. So let's move to next speaker. Next speaker will be Dr. Pian Chen. Pian Chen from Westmed Hospital, Sydney. And Dr. Pian Chen is a clinician scientist based at the Westmed Applied Research Center and clinical academic in Western Sydney local health district, specializing in the treatment of heart rhythm disorders using minimized invasive catheter ablation. And Pian Chen, so it's nice to meet Professor Pian Chen. Nice to meet you here. And you are so welcome to, it's our great honor to have you here to give us a presentation. And today is the title of the speech is the zero flow catheter ablation for complex arrhythmia, tips and tricks. So, Dr. Pian Chen, please.
Thanks very much for the kind introduction and the honor to speak today at this meeting. Can everyone see the shared screen there?
So, yes.
Yeah.
Very good.
So this is our hospital at Westmead in Sydney. So we've got a new building here and a lot of research institutes around. So I'm very happy to talk to you about some of the work that we're doing in zero fluoroscopy. I think the previous two speakers have really already spoken a lot about some of this content, so I'm going to go very quickly. But I want to point out that that fluoroscopy procedures, like the EP procedures, were very fluoroscopy heavy for some time, and the natural history of doing EP, I think, has seen that with more complex and better mapping systems and intracardiac echo and better three-dimensional anatomy appreciation, we've been able to reduce the fluoroscopy in the EP lab. And I think this is a part of the natural evolution of how EP is going to be performed in the future. Um, we, I won't go through this too much, but obviously there are some cancer risks for using radiation. But as Dr. Jiang said in the previous talk, what is striking is the amount of orthopedic injury that operators experience. And this is a study done at an Italian cardiology convention where people were surveyed as to, what their medical background or conditions were. And according to how many years they spent in the cath lab, you see more than 16 years spent in the cath lab, there's a huge incidence of orthopedic injury, cataracts, hypertension, and so these people are less probably got poorer mobility and are have metabolic syndrome and also have spinal injury. And we know that many of our colleagues have spinal problems later in life because of wearing lead. So the minimization or the elimination of fluoroscopy really relies, as what's already been discussed, on better three-dimensional anatomical appreciation through imaging, pre-procedural imaging, intra-procedural imaging with ICE, with TOE, and also, I think this three-dimensional appreciation of anatomy and substrate, and also this greater focus on electrogram interpretation, really helps us understand electroanatomical substrates and arrhythmia mechanisms, and I think leads to better catheter manipulation skills as well. So a little bit about our workflow. When I practiced, trained in the US with zero fluoro, we did everything with ice. But coming back to Australia, last 5 years, we've adopted a toe-guided zero fluoro workflow. So I'll talk a little bit about that. But this is for AF ablation, we use mostly toe to guide the transeptal puncture and then the electroanatomical mapping system to the rest of the procedure, zero fluoro. But with VT and complex congenital patients, we use ice. Now, we start with a catheter with ultrasound-guided vascular access, as the other centers would as well. But I just want to point out that there's always this anterior flexion point. So for the newcomers to zero fluoro techniques, often this area in the iliac veins is where people get stuck with their catheters. So a couple of tricks here. With non-deflectable catheters or deflectable catheters, you can deflect it first and point the loop upwards. So when you insert it into the short sheath, it will have this anterior direction, and this will help it go up the vein without getting stuck. Do not try to manipulate the catheter when it is down here because you may not see it on the mapping system accurately and it's not reliable. So point the catheter flexion up and then advance like this. Often it gets you through this area. Before we had nav-enabled Deca navs, we also use CARTO. We also used to get the anatomy first with the ablation catheter or with a nav-enabled catheter first. But now with Deca nav, this is no longer necessary. So you can just simply go into the CS, get respiratory gate with a Deca nav and go into the CS. But we used to do this routinely with the ablation catheter. And so it takes a little bit of time getting used to cannulating fluorously the CS, but you get into the V first. See the ventricular electrogram, pull back as you clock. So you're in front of the valve. You don't want to get stuck behind the CS valve. So you always go into the V first, deflect and clock. And if you're using TOE, you can also visualize a CS ostium. We used to do this, but we never do this now. It's so easy to get into the CS once you're used to. You use a F curve Deca nav. It will give you a better reach into the ventricle. I think the bigger curve is better. In the past, we sometimes had difficulty with D-shaped Deca navs, but with F-shaped, we now never have any problem. And this is the bicaval view in TOE. This is the same. You can do a same view with an ICE catheter with posterior tilt and a little bit of a rotation. You can see up the SVC. But here the bicaval view is great for pulling down in the transeptal. You can see your wire pull down and until you tent, and this is it's all fairly simple on a bicable view. This will tell us how high and low your transeptal puncture will be. You can also choose to clip the transeptal needle if you want. We used to do this, but it's not necessary to do. But if you do this, you can visualize the transeptal needle as a 2 millimeter electrode on the mapping system. This works in all mapping systems, and so you can tell where you've tented, where your position is. These other dots that we have here, the blue dot, and is where we put the ablation catheter there. We mark the mid transeptal point because we tend to do a double transeptal puncture. Well, we do a single transeptal puncture, but we put a sheath and a catheter through the same puncture. So we'll get back to that. Once we've punctured, and then we make sure that the wire is in the left superior pulmonary vein, and you can see that sometimes at 50 degrees. 50 degrees is a good view, equivalent to the ice, where you can see the length of the catheter. So usually, 50 to 70 degrees, you can see this length of the sheath. Sometimes you need to be a bit flatter to see the wire in the left superior on toe. So if you can go to 20 degrees and pull out a little bit, and you should see the wire. See, this 50-degree view is a little bit like the ice view. You can dilate safely. You can see your sheaths cross. And if you want to, you can also clip your wire and visualize the wire in the same way as a 2 millimeter catheter. So if you do this, you can see the wire position being stable when you're doing your dilatation. You don't have to do this. We don't do this routinely anymore. But in the beginning, when you're going to a fluoroless workflow, this may help just to as a further safety check. We pass the ablation catheter through the same transeptal hole. So the trick with this is on CARDO, if you are touching the wire with your ablation catheter, you will get this high force metallic clash alert. You won't feel any force on the catheter. But when you get this clash, it means that you've fallen through the transeptal hole. You're touching the wire. So at this point, you should feel no force and you should be able to go across. And then we use usually a Visigo, but you can really use any sheath. This Visigo is nice because you can see the sheath. And then we dilate, so we get 2 sheaths across. When you take the dilator out, but you keep the wire in the SL0 sheath, you'll be able to see that it has this tram track view. That way you can make sure that the end of the sheath is in the left atrium. So that you've put the whole sheath into the left atrium, you can then put your catheter in. So that's often very good to check that the empty sheath is in the left atrium. So we don't do any pre-procedural CT scans. We rely on just the electron-anatomical map to generate the left atrial anatomy. So I tend to use a pentarray or an octarray because this will allow better definition of the pulmonary vein branches. Particularly if using PFA, it's nice to see the pulmonary vein branches and be able to put your wire, select different branches. So you just have to be gentle and not generate push out. But with the pentarray, I think this is very achievable, and it gives you a good substrate map as well, which can help. So we started doing a fluoroless technique in 2020 using the toe-guided approach, and we basically moving from a fluoro to a zero fluoro approach takes about 40 cases to start getting your transeptal time down. So the most of the time is spent between setting up the patient and getting left atrial access. And so this you can see has really reduced substantially with the zero fluoro technique. Now is, we think, faster than fluoro for some reason. I think this three-dimensional anatomy appreciation sometimes can help with the transeptal puncture as well. You will find as you look at more of the ice and toe, some patients are very rotated and have a bit of a strange transeptal side. But and we find really the total procedural time is reduced with our zero fluoro technique, interestingly, compared to fluoro. And this is not skin to skin time. This is the patient turnover time. So the time it takes to get the next patient on the table. So this is really quite good, I think, with the zero fluoro technique with the toe guidance. And I will just say that in the era of PFA, we've started to clip the wire again because, see, we can very clearly see that we can use the wire to select the branch that we want to guide the PFA system, and this is with Farapulse. Now, I'll talk a little bit, a couple of cases, which we're doing VT cases. With VT or PVCs, we like to use ICE guidance and also CT or MRI imaging guidance to help more rapidly, more efficiently localize the arrhythmia substrate or the VT circuitry. So this is a congenital patient who really had a lot of pulmonary repairs and palliative shunts for pulmonary atresia and a VSD repair. And she has had a lot of PVCs, and these are very debilitating for her. She actually is very physically active and goes sailing, but she really gets very short of breath with PVCs. And you can see that she's got this right bundle branch block, the PVC, probably periaortic, but it's a little bit less positive than a right bundle. It looks like a periaortic PVC. And we imported the CT imaging pre-procedurally because she has a lot of calcium in her outflow tract. You cannot see much in her using ice because the views are all obscured by calcification. So this green is the pulmonary conduit. This green structure here, down here, is her right coronary artery, which is reimplanted or anomalous, so basically we are here. These are the cusps that are identified on the ice, and we really cannot see the right cusp. We can see the left cusp, a little bit of non-coronary cusp, too much calcium to reconstruct with ice. And this is the QDOT catheter, and you can see how early some of these PVCs are from the right coronary cusp. So some of the PVC, this is here, some of how early the signals are on the microelectrodes on the right coronary cusp. And so we ablated some sites on the right coronary cusp, inhibited the PVC, and then they started again, and we found some earlier sites on the left-right coronary cusp junction, ablated those, and she has basically eliminated her PVCs, and she came back, PVC free and feeling very good. But this is some CT imaging here where we ablated, and also we use eyes to look at a VSD patch, identify where the VSD patch is, which is here. We know where the coronary conduit is, the pulmonary conduit is, and we know the His bundle, His electrograms are, and so we're ablating in this area fluorously guided entirely by pre-procedural imaging and ice. And so this is the ice sweep after the procedure. These are the His points down here. These are the higher points where we ablate. We can only see the VSD patch, but the ice here is not very helpful, unfortunately, because of the calcification. This is another patient who has a non-ischemic cardiomyopathy, previously unrecognized, who presents with sustained VT and cardiogenic shock, 40-year-old female. Her ECG shows VT going about 200 beats a minute. This right bundle, basal septal or basal inferior type of focus. And her after reversion to sinus rhythm, after cardioversion, impressively, she has these fairly delayed QRS fractionation in the inferior leads and anterior leads, which are quite impressive. A lot of delayed scar, it looks like, in the inferior septal region. So she had an MRI scan. Her EF is 30 to 35%. She's got a very large scar burden that affects most of the septum and inferior wall. And EF was reduced in the RV as well, just basically very poor, unrecognized cardiomyopathy, undifferentiated, and presents with this VT. So with the MRI information, we can get that into ADAS. You can also use InHeart, or previously known as Music, and the program will segment the scar information and the wall thickness information, give you VTK files, which you can import into the electroanatomical mapping system. It also processes the LGE pattern and the wall thickness and gives you this channel information. So from the ADAS, it's telling us that maybe there are these channels in the septal region of this scar, which is quite extensive and dense. But these are areas that are relatively spared. And this is another view of what the program thinks is the channels through this septal scar. So we took her to a procedure, and here we induced VT. the clinical VT that we induced has a excellent 96% match from this septal channel area with a longer stim to QRS. And we can pace down here as well with a longer stim to QRS. So it looks like this scar, VT exiting this scar through this channel. And the second VT we induce is more basal septal, and this is a different morphology. And here we have the shorter stim to QRS from the base of this scar, again related to this channel region here, with 95% match. So very, very good correlation to the MRI detected scar. So here this is our lesion set. She has these two VTs, which we treated. Basically, we're transecting the channel areas in the scar. And she has a further moderator band ectopic bead, which we ablated on the left and ablated on the right. We don't see the lesions, but we ablated a moderator band area on the right. So after this, no VT was inducible, and she's off amiodarone and perfectly well and free of VT now. And when we are ablating VT, whether it's pap muscle or any sort of VT, it's nice to have ice and watching the contact at the site of ablation, and particularly useful, obviously, for intracardiac structures. So I'll just conclude by saying that that this zero fluoro workflows are adoptable and they can be efficient. And we have used a toe-guided fluoroless approach in AF ablation because our patients are under general anesthetic in Australia. So we always have a toe probe anyway, so we can avoid using ice because of the cost. But of course, if we're doing procedures under sedation, we will use ice. And if we do VT, we will use ice because of the anatomical information from ice is very important, and monitoring. The pre-procedural CT and MRI information can be imported into the study and processed. This can be very helpful in some patients, not all patients perhaps, but very helpful in some. And I think the one benefit that should be emphasized with the zero fluoro approach is that as an operator, I find that I am focusing more on the electrograms, which are the real thing about EP. We're focusing on the three-dimensional anatomy, which again is an extremely important part of EP. We're not relying on looking at the black and white two-dimensional image manipulating our catheters. So and the third thing is that we're doing it very comfortably. I tend to sit down, play some music. I don't have any lead on. No one else has lead in the operating theater. Everyone is very comfortable. So for long and days in the EP lab, also for very difficult cases, it's good to be relaxed, and that frees up your mind to think very carefully about the case, and you don't get frustrated. So I think all of this can only be good for the patient, good for the operator, and should lead to better outcomes. Thank you.
Thank you. Great talk. You enjoyed the procedure, with a lot of fun. But for me, like this kind of VT, very complex, and maybe patient develop into hemodynamic I mean instability, and it's very challenging. But with a very skilled hand, it make it very, very safe. So it's amazing job. It's a great talk. And maybe we let's move to next talk. And thank you very much, Dr. Chen. And Dr. Yamashita.
Yeah.
The
Okay.
next talk will be
Yeah. Okay.
Wrong.
Okay.
Please.
Next speaker is Ronghai Yu from Beijing Ansen Hospital in China. And he's the chief physician in Beijing Ansen Hospital, vice president for medical affairs university. Yeah. And the session title is Safety and Efficacy of a Novel Pericardic Puncture Technique with a fluoro. So I've never been tried to pericardial puncture with a fluoroscopy, so I'm looking forward to hearing your presentation. Yeah. Please start your presentation, Dr. Yu.
Let me check.
Where is?
Sorry, maybe Dr. Yu is not available now. He's still busy
Okay.
in the other presentation. Maybe let's move to next talk.
Okay.
Yeah.
Okay. Next speaker is
Let-
Yin Cho
Yep, that's me.
from Ansen Hospital. Yeah. Okay. Yes. Technical point of transducer puncture in left atrial appendage occlusion procedures. Yeah. Dr. Yin, please start your presentation.
Okay. So let me share my screen first. So you guys see my screen?
Yeah.
Yes,
Great.
please.
Okay. So good afternoon, everyone. My name is Nim Zhou. I'm from Anzhen Hospital, Capital Medical University, China. So the guy just jumped. Dr. Yu is also work with me together. We are colleagues. So our hospital located in Beijing, that might be one of the biggest medical cardiovascular hospital in the world. Last year we finished around 10,000 cases of the atrial fibrillation ablation. So hopefully we'll finish might 10,000 and 15,000 cases this year, because we have 50% percentage of the shift compared with last year. So we did some ablation, did a lot of ablations, but our cases of the LAAC is not so many. We finished around 800 cases last year. Kind of that's numbers. So we don't have very many experience to share with you guys, but I'm very honored to be here, to be invited to give you a speech. So my topic is the technical essentials of the atrial septum puncture in the leg. So this is a very basic technique for us to do the leg. So I'm glad to share my topic from the four aspects. The first one is pre-operative chest CT assessment of TSP. First of all, before we do the procedure of leg, we usually to do a chest CT for the patient before the procedure. So we want to see the multiplanar reconstruction images with the axial, sagittal, and coronal orientations to see the angles of the atrium septum. So the first angle is the axial orientation. So angle 13, 13 forward tilt to the right. The next aspect is sagittal orientation. So inclined 10 angles towards to the lateral side. And the third one is the coronary orientation is RAO 30 and the crane 10 to see the angles of the transeptal with the coronary side. So this is appropriate TSP side. In the cross-sectional view, the atrium septum section can be identified. We'll draw a vertical line as assigned as a blue line on the atrium septum. And the angle between this line and the mid-ventricle vertical line showed as an orange one can be used as angle to determine the anterior-posterior position during the TSP. And this is image show the shafts into the left atrium after TSP. So in the coronal view, the locate the plane where the left atrial appendage is present. In this view, you'll see the relative position of the atrial septum with respect to the LAA and evaluate its height. And the right one is rotated the transverse plane along its axis to align with the LAA and achieving optimal axis view. In this view, we can observe the anterior and posterior relationship between the LAA and the atrium septum. So we can do the TSP by both by DSA or by the eyes or by both. So in my center, we do as both actually. We do the TSP mostly by DSA, but most of the case we also use the eyes together. So this is imaging characteristics of the TSP by guided by the X-ray. So you can see a relative position of the left and right atrium by these images. So obviously we can see that from the RAO side, you can see the LAA is located from the backward of the right atrium. And from the LAO side, we can see the left atrium is located from the right side of the right atrium. And this is a video to show the TSP under DSA and under the anterior and the posterior view. We can determine the height of the TSP site by using this AP view. We can restore the catheter downward from the superior ventral camera, and we can see the catheter is slowly withdrawing and making two consecutive jumps. But most of the jumps is variously from the right atrium into the RAO fossa. And this is the location of the FO from the right RAO side. Guided by the DSA and from the RAO side, we can determine the anterior posterior view of the TSP site. And the direction of this puncture needle tip is nearly parallel to the spine. And another view is guided by DSA on the LAO side, AO 30 degree, and determine the depth into the LA. And from the video, we can see the tips of the needle is already into the right atrium of the septum, atrium septum. And once the needle is advanced through the atrial septum, we can inject the contrast into the left atrium and visualize this flow. If the contrast agent flows in a straight line, it indicated a successful puncture. And also we can do the TSP guided by eyes. And if you can use both, that's much safer and effective. And this is the image shows the TSP guided by the intracardiac echocardiography. And we can also see the FO by the septum view, and also this tiny sign. If you send send the needle and locate into the right atrium of the transeptal atrium transeptal, and also this image shows that the shaft across the FO into the left atrium. So this is a image shows the TSP guided by eyes, and we can use the ultrasound to demonstrate the FO and the left pulmonary vein, to see like rapid airs, and from the home view sector and clockwise rotate the handle towards the FPV sector. And this is a TSP guided by the eyes. The image show how to rotate the eyes to see the correct views, which is very useful for us to do the TSP. And here we show the tendon signs when we do a TSP by guided by eyes, and it shows an ideal position. And this tendon is direct towards to the LAA or after the puncture, and the catheter easily enters the left atrium. And if we do a good TSP, that might be easier for us to do the LAAC, and will show the impact of TSP on occlusion effectiveness. So before exchanging the delivery shares, how to determine the axis height of the shares? So here show are not good. That's very bad axis of the LAA shares. It is too high for us to do the leg. So this is the case show a too high TSP site and redo the TSP for another time. So this is the first video show before the reshaping. We do the reshape of the shells. The acidity is too high, and the caster is not so the axis is not so good for the caster into the LAA. And then we withdraw the caster and to rebending and shape the tip of the caster at 45 degree, and then the shells is coexist with LA much better than before. And we do the angiography, and then this is a fish hook like reshaping of the shells, and we complete the opening of the umbrella. And this another case shows a high axicity and reduce the TSP. So here is the height of the TSP site. The first TSP, the angiography shows the anxiety is too high, and they choosing a lower puncture like here to further reattempting achieving an ideal axis alignment. And the comparison of the axis alignment before the two puncture attempts. This is too high TSP site. This is another appropriate TSP site. We can get a very different axis of the shape with the LAA. And for the below one, that's much easier for us to do the leg. And reduce the TSP, we can get a very excellent axis alignment like this one. The umbrella opening is already finished, and then we relieve the another occlusion to do the occlusion of the neck. And this is a view of RAO and CAU. And this is another case show ideal axis alignment. The perfect occlusion can be achieved even in a reverse chicken wing or a shallow LAA cases. So this one we can see the LAA is a reverse chicken wing shape. So this is very difficult for us to do the leg for a regular cases. And we do a very good TSP before we before the procedure. So this is a very satisfactory occlusion and achieved in the right in RAO 30 degree, and also to show the occlusion is very satisfactory, and we test the stability. Here below the images shows video, and the images showed the eyes videos to show the stability and occlusive of the leg, which is very satisfactory. And after releasing and multi-angle images was performed, but no contrast enters the LAA. It shows this is very satisfactory, and occlusion devices is perfect aligned in this orifice of the LAA. So insight from the impact of axial alignment of the leg, and firstly we suggest to do the preoperative CT evaluation, allow assessment of the relationship between the LAA and the atrium septum. And secondly, we suggest do the ICE test, which can provide a more direct and safe visualization during TSP. And prior to the exchange of delivery sheath, using the transeptal puncture sheath for LAA imaging, which is very helpful. And reshaping the delivery sheath can help us to achieve a more optimal and axial alignment. And if the axiality is too high, the septum puncture is recommended, which can help us to do a much easier procedure. And a good axial alignment is crucial for a successful leg. So in complex case, achieving an ideal ideal axis alignment can result in a perfect occlusion result. And in the simple cases, poor axis alignment may require multiple adjustments and which may lead to more complications during the procedure. So that's all. Thank you so much.
Thank you, Dr. Cho. Dr. Cho gave a very informative talk on using pre-procedure CT imaging and procedure ICE image to get transeptal puncture during LAO procedure. I was truly amazed to hear that their annual case volume is around 10,000. That's more than 10 times the number at our center, where we perform about 800 to 900 cases per year. In Japan, many centers do obtain pre-procedure CT scans, but few utilize images as extensively or in such detail as shown in Dr. Cho's presentation. It was very insightful and gave us a lot to think about. Thank you, Dr. Cho.
Yeah, thank you, Dr. Joe. Yes, it's amazing. I did, the busiest, the biggest center in China, maybe in the world.
Mm-hmm.
And let's move to next speaker. Next speech is from Dr. Rong Huiyu. Rong Huiyu is, yeah, he's now he's yeah, he's because the camera is open, and he will talk about the safety efficacy of a novel pericardial puncture technique. It's a very creative way method. Dr. Yu, please.
Okay. Distinguished colleagues, this class is use of three-dimensional intellectual anatomic for epicardial axis. I'm Dr. Yonghui Yu from Beijing Anzhen Hospital. The research has been published in 2020 JACC cardiovascular intervention and 2024 Europace. Overview of epicardial access techniques. Background: dry epicardial access, epicardial ablation, and wide epicardial access. Pericardial anatomy. The fibers of pericardial also provide electrical insulation. That's the important characteristics. Development of epicardial access techniques. Early epicardial access techniques relies on surgical shuntotomy. You say the surgical is the only way. Now, develop the epicardial access techniques, subsidiary techniques. You say one from the subsidiary that we developed the right anterior oblique views at 60 degrees obtained by fluoroscopy during the epicardial mapping procedure, first performed by Shosha in 1996. Let's say background and the basics, the application and the limitation of ICE. 3D electroanatomic mapping guided epicardial access is very difficult to track the needle tip in real time while using ICE. Due to the maximum imaging depth of ICE is not exceeding 16 to 18 cm. It's not recommended to track pumpkin needle during punctures. Let's say the JACC intervention. Background and basics, enlightenment of 3D ENAM endocardial access. At first, when you target the 3D EM endocardial access, let's say, is the 3D EM TSP method. You say needle tip. So I say we can continue another method of epicardial method. 3D endochemical mapping guided epicardial access. We use access needle tip and collection. You see, we collect with cartol the tubule, the needle. You see, with a plastic tip. Now, you say any studies we forcing 3D epicardial access. Creation of the in the corridors based on the surface of the body. Blue dot, let's see, the blue dot. Ribs 3 to 6. RV and IV anatomical modeling with ablation catheter. 3-dimension imaging of the needle tip, yellow, and the mapping of the unipolar potential. Unipolar potential, let's say light potential, A. Let's say A. The needle tips, location in the medial stem, and the unipolar potential is small. I look at the potential. Like the needle tip is close to the epicardial, and the unipolar potential becomes larger. Let's say become larger, the potential. Like the needle tip touches the fibrous pericardial and enters the pericardial cavity. A huge potential appears. Let's see, huge potential with red arrow. The needle tip entered the ventricular cavity and the potential becomes smaller. Let's see, the track is very accurate. That's porcine 3D epicardial access. In body, human body, 3D epicardial access study, the same person. That's the XV. That's the 3D epicardial access study. After I say 3 CT reconstruction, RV, LV, LO, LAD, LCX, RCA, middle, 3D XV, middle, 3D XV. Right, unipolar electrogram Chinese driving puncture. You see a needle in the medial stem, small potential distance from cardiac base. Let's say B. Let's say B. Collected with fibrous pericardial, large potential, meaning the injury current, distance from coronary arteries. C. Entry into the pericardial space, giant potential, injury currents. Uses indicate epicardial irritation. Let's say the large potential and with irritation. Now I say the gateway. The validation of straight potential pericardial centrifugal success. Gateway migration. We use gateway. You see, in here is a large ventricle wave. Then with the atrium wave and ventricle wave. Now say the good track is accurate. Now right is X-ray, left is 3D mapping. Three-dimension actual anatomic mapping guided epicardial access. Unipolar potentials characteristic recording the during the needle. I see as animal X period with as 30 on the way to the pericardial cavity and the application of the unipotent protein increase significantly and gradually. And the 2 grams, which is the statistical difference, the technical trial treated with results of animal experience N22. And you see A steam. Now we say the small potential fiber pericardial, yes, MP with larger potential. Now with I can say one ventricle, I say it's the same characteristics. Now the breakthrough point analysis, you can say in both potential, the needle tip was looking at the breakthrough point, the pericardial cavity, which was confirmed by the permeable ventricular contraction on the electrocardiogram and the injury current on the needle tip. A left. 41-year-old ARV potential. The breakthrough point is very close to the endocardial edge of the 3D reconstruction. B right. 67-year-old DCM potential patient. The breakthrough point is far from the cardiac edge of the 3D reconstruction. And I see we use T3D cooperation with the ultrasound enhanced cardiac reconstruction accuracy. I can say 3D, yes, with EM reconstruction. It's in the inner, the outer space is reconstruction by ultrasound. You see, is the good accuracy. I can say needle tip at the middle stem in the fiber pericardial that's into the pericardial cavity. Now we see the gateway, the needle tip, and is gateway GT. The gateway tip as is the same. In the same way, we can confirm the success. Now see the video. That's the needle tip. Now near the fiber pericardial. Then look at the potential PVC that collect the cavity. Needle tip. Then look at the gateway. I say with the same way. Say again. That can confirm the success. Then we exchange the teeth. Clinical cases. Let's say the needle tip. Look at the potential. Then look at potential change. Look at disturb and PVC. And look, PVC change with gateway that confirm the success. Now look at the zero epicardial size one pericardial template. We use the same form in pericardial template with zero radiation ablation of the needle tip approaching to the pericardial and the guidance of the 3-dimensional electro atomic system at the same. And then look at in the medial system and look at near the approaching to the pericardium, close to the chest way, left, right, approaching to the pericardium. Now I say the total workflow. Now I say with without any DSA, to no DSA, now the collection. Now let's see the diagram. I see the fiber pericardial into the cavity. The potential changes. Needle tip is the real process. Now with a get well, the real clinical disease. Summary. Three-dimensional electro anatomic mapping system provide precise needle imaging. Characteristic unipolar electrodermal changes distinguish pericardial nails. 3D guided exercise offers a low approach to pericardial puncture in the electrophysiology laboratory. Improve safety in zero irrigation electrophysiology laboratory. Thank you.
Thank you very much, Dr. Yu. Actually, congratulations. You know, it's you are a brave man to do pericarditis puncture without fluoro. It's very scary, but very successful. You very successful. But first I have a question. One question for you. It's irritation regarding irritation. The PVCs. Is the PVC is safe? It's safe. Usually PVC means you're touching the epicardium of the ventricle, and either way, lacerate the pericardium and damage the coronary artery. It's some small vessel of the coronary artery. And did you have some bad experience with that PVCs?
I have reported 6 out of 22 patients have PVC. Not one. You say when we use pericardial kind of total avoid the PVC. And also, I think the unipolar electrogram recorded from the pericardial synthesis puncture with PVC don't mean the wrong. Also, we shows the characteristic for the subsequent to the pericardial space. Then real-time tracking, I think, can avoid the more damage. I think, and I don't care more about the PVCs.
I see. Thank you. Thank you. So maybe we have several minutes to discuss, several minutes more for discuss. So yes, please, Dr. Pianchen.
I really enjoyed that talk. That was a great talk and very interesting technique because I would love to do zero fluoro epicardial access as well. Then I think with CT imaging and coronary artery definition, I don't need to put on lead at all in the, in the EP lab. So I think that's great. I want to ask about the unipolar EGM. What is are you using the grounding patch? As the other pole for the unipolar, or how do you set up your unipolar EGM? Do you do unipolar? So it's the needle, you clip the needle, and then patient return the electrode like the patch on the leg, or how do you do unipolar?
Unipolar potential is easy to record. Just ask BW CCS, they can with match the PPT we can we有一个the same data we can record accurately.
Okay. And
Mm.
if you get the ST elevation, you get the injury current. And like when you get the injury current, you then stop and try the wire. If the wire doesn't go, then what do you do? Do you push a little bit more, or do you pull back and you just try again? Or if the injury current, you see the injury current, you try, it doesn't work, do you pull back and try with a wire?
Even PVC or anti allegation, we should stop approach. When stop approach, we retract the needle. And sometimes we 看怎么说呢？就是we check we check the blood. If we enter the blood, we can stop the main operation.
Yes, sometimes it's very tricky actually. And actually, I think it's very promising. It's possible to do without fluoro, for sure. So let's wait and see. And
Doctor, can I ask a question to
yes,
Dr. Yu? Thank you for great presentation, Dr. Yu. I think a magnetic field is necessary to visualize the wire in a 3D mapping system. So how do you obtain the magnetic field, matrix, within the epicardial space in advance? Is the magnetic field generated from the RV endocardium sufficient for this purpose? So after pericardial puncture, I think the magnetic field is necessary to visualize the wire. Is that correct?
Sorry.
yeah, I think so.
Sorry, can you repeat?
Okay. I think magnetic field. So in Carto, probably do you use Carto system? Carto system? Carto 3D mapping
Yes,
system?
we use color system.
Okay, yeah. So probably I think the magnetic field in Carto is necessary to visualize the wire in a 3D mapping system. So I think you need to obtain a magnetic field within the epicardial space in advance. How do you get the magnetic field in epicardial space in advance? So we don't need the magnetic field in epicardial. So are we able to get RV endocardium only? Does that make sense? No? Okay.
From my point,
Yeah.
from my understanding, it's not necessary to obtain the matrix of a
Okay.
magnetic field with like inside. You use the electrofield
Yeah.
guided to obtain the difference, the changing of the potential from small potential, unipolar potential to big potential, and some injury potential of the ventricle pericardium muscle. That makes sense, I think. Maybe
Okay.
yeah, interesting. And Dr. Yu, maybe you can send us your paper. Send us your paper for more information in detail. Yeah,
Okay.
it's lots of us are very interested in your innovation. And actually, I have one question for Dr. Uh, yes, Yamashita. So in Japan, you nowadays, do you do PFA uh, uh, mostly without fluoro
Mhm.
in Japan?
Oh yeah. Yeah. We don't wear lead, and we usually perform PFA in patients with atrial fibrillation without fluoroscopy.
Without.
Yeah,
So
without
if a
fluoroscopy. Yeah.
patient develop into like atrial tachycardia, atrial flutter,
Mm-hmm.
do you
Oh
use
yeah. No. We, no, we don't use fluoroscopy because we're able to use RF catheter as well. So radio frequency, Q dot or some STSF. So we're able to map by using Optoral multi-electrode mapping system, and after taking the 3D mapping system, so we upgrade by using RF catheter.
sometimes
Mhm.
the lesion is reversible and sometimes irreversible, and it's
Mhm.
different from RF. It will
Mhm.
come, the potential will come back in very soon, in very short time, maybe 20 minutes. But
Mhm.
in PF, usually takes a long time. So
Mhm.
how do you to improve the
Mhm.
quality of the lesion, of the irreversible lesion?
Uh, yeah, that's an interesting question, and that's a difficult, I think so. As you know, so we're able to know the durability in and during procedure. So yeah, we need to get better contact and stable contact during the procedure. So we always use general anesthesia,
Yeah.
uh, yeah, to stop cardiac movement and stop cough after PFA application. That's the main issue.
Yes.
So
GA is very
uh,
important.
yeah, I
It's
think that's very important. So how do you know the uh, PV durability during the procedure as well? So how do you have any suggestion or something?
uh, I think ice very important
Yeah.
to give us a good
To get mm,
information,
mm,
information in
contact.
detail about the contact. I think good
I
contact is
see.
very
Yeah.
important to
Mm,
make a
yeah.
durable
Mm,
lesion. But
mm,
sometimes
yeah.
the quality of the
Mm,
ice is very bad.
mm,
The
yeah.
very
Mm,
echogenic. So
mm,
to appreciate the good contact,
mm,
if the contact is good
mm,
or not.
I
Yeah.
agree with you. Yeah.
Yeah.
Mm,
So will
yeah.
you advance ice into the left atrium to appreciate good contact or not?
Yeah. If we are able to insert the eyes in the area, so it should be better to know it should be better how to contact the caster, or but it's a bit complicated procedure, so we don't put the ice caster in the area. We just put the caster on array only.
Yes. And
Mm,
another my concern is, heart is beating. It's not like other
mm,
organ. It's not
mm,
moving. It's beating,
mm,
and bleeding.
mm,
And
mm,
sometimes the contact, it's
mm,
on and off, on,
mhm,
on
mm,
and off. And
mhm,
the application of the energy is very short.
mm,
And
mm,
maybe
mm,
and very unfortunately, the energy
mhm.
is delivered during
Mm.
the, during the time of bad contact, bad contact.
Yeah,
So,
I see. Yeah,
so,
that's yes,
so
that's a big problem. Yeah.
yes,
Mm,
because this is
mm,
the forum is about the tips and
mm,
tricks. So what's your tips and
mm,
tricks? And maybe this question also for Dr.
mm.
Chen to make a good contact.
what you say about the beating during PFA, like the
Yes,
movement,
yes,
is very true because when we sometimes get these two, we do pairwise isolation, they get too close. I think sometimes that is because of the roof. The when you're giving PFA, you get a lot of phrenic movement, or you get a lot of stim or something, and the catheter is sliding when you're giving the
yes,
movement, and particularly with Varipulse, sometimes I think because it's on the mapping system. The mapping system shows there's a ring like this, but the lesion is much bigger than the ring. With a pulse select, it's not like that. And it's much small. It's much more like where you're getting the ring, but the Farapulse is bigger than the way it's rendered. So even more easy for it to slide and then get close together. I think it's
mhm,
very difficult. We do the procedures under general anesthetic, so we can paralyze the patient, although we don't routinely, but we can very well paralyze them. So that would reduce the movement during PFA. Of course, if you're doing it under sedation, this is much more difficult, particularly sometimes the patient may be coughing or something, and even more movement, not just cardiac. The whole body is moving, you know.
yes, yes.
So this is challenging. Um, so I don't have a good answer, but I think again the position of the catheter on the ice or on the toe in those veins to make sure that they're in good contact to start off with, and sometimes the ridge is different in every patient, and making sure the how the splines are sitting on the ridge and not too anterior and so forth. And I think this is very helpful. So
Yeah. So maybe I have one more question for both of all of you regarding the linear ablation. Do you do linear ablation and PFA linear ablation for your patients, like a isthmus line and something like that?
yeah. We have done, and uh, I mean we did that more before all the data came out that the linear ablations may produce some subclinical coronary injury and intimal hyperplasia. After that, we're doing it less. But I have done almost every line. Lateral mitral isthmus, anterior mitral isthmus, SVC to IVC line I've done in patients, CTI line plenty, SVC isolation. And all of those are possible with different PFA systems, but with Farapulse, we have most experience. The lines with Farapulse tend to be very broad, which is sometimes a bad thing, sometimes a good thing. I find that anterior mitral isthmus line is easier. I don't know other people, but Dr. Yamashita can comment as well. I find the anterior one blocks more reliably. The lateral one, sometimes I've had to touch up in the coronary sinus. I think the coronary vasculature is bigger there. So the CS connections you cannot get with PFA. Um, I think it's very easy to do, but whether it's the best for the patient, I'm not sure compared to RF.
Yeah, yes, yes.
I agree with Dr. Kian. I've done several CTI ablation and mitral isthmus and anterior mitral isthmus line and posterior wall isolation. But uh, recently we don't do mitral isthmus and CTI block line because of we are afraid of coronary spasm. But we usually we usually do posterior isolation and anterior line and SBC and PLSBC isolation by using pulse field ablation system. So it's quite easier than summer ablation, and we don't care about collateral damage.
Yeah, thank you. Yes, yeah, I really enjoyed the presentation. Dr. Ruhong Jiang, what's your comments? Do you have any questions or comments?
Yeah, actually, I'm very interested about the talk presented by Professor Pio Chenqian. Yeah, very very great presentation. I'm interested about your VT case about with ADAS software. I saw several I can saw the scars, and also I can saw several green, very bold green lines. Maybe indicate the isthmus or gaps between the scars. So, do you think what about the accuracy about the green lines? So we need to update all of the gaps. We still based on the other VT mapping.
Yeah, I think it's just one extra piece of information to have, but you need to use all the information you have, and of course when SCAR is the ADAS or InHeart can extract some useful information. Say in ischemics, it can show you the wall thickness. So we know wall thickness less than half a mil 5 millimeters or 2 millimeters, is you have more substrate, right? But it doesn't tell you where it is. Sometimes the imaging is good enough, you can see these channels. And when you see the channels, of course, it helps you go to the right place faster, maybe. But you have to approach this case in the same way. The way I do it. I generally look for channels electrically. Of course, I didn't show it, but we usually tag late potentials, delayed potentials. We take the fascicular potentials, the bundle branches, and we pace map. We look for long stem to QRS, look for change in morphology. So all of those things we're looking for at the same time. But when the scar is very big, and sometimes it's helpful to have more information to help you focus on certain part of the scar. In the non-ischemic cardiomyopathy, you look for unipolar voltage as well as bipolar. Understand where the epicardial scar is, understand from the VT where it could be exiting. Of course, the ECG only tells you the exit. It does not tell you all the circuits. So you have to imagine a little bit from your eyes, from the ICE image, from the MRI or CT or ADAS, if you have it, from the electrogram information, imagine where the circuit is or where the focus is in the substrate.
Okay, thank you. So, yeah, I to go to went to learn about the ADAS software last year, but the software looks a little bit expensive to when we need to buy it. So, is it a very routine practice in your center, or you did the model locally, or sent your images to the company and the company said back about the model?
Yeah, so ADAS is you buy the package and then you can use it as much as you like. InHeart is you send the image to InHeart, they per case and they send it back. One important consideration is the quality of the imaging. So a lot of our patients have devices, right, when they have VT. When we have a device, even if you have a broadband filter, for the MRI, it's very noisy usually. It's very hard to get any channel information. Patients with devices, probably the CT, contrast CT is better. And you can do delayed contrast CT. Sometimes you can see channel information, but often you don't. You may see just wall thinning information. So that information you can also get from ICE. So I would say a lot of patients we have, ADAS or InHeart is used in the minority, but when we have good imaging, it can be very nice. They can add a bit more information. We still use a lot of ice, and we're looking at the procedure. We see where the scar is, and we can draw on the ice and draw out the scar. That can help us as well, right? So I don't know how much ADAS is now. I think when we purchased it, it was not that expensive compared to the cost of EP procedures. So I guess expense is a relative thing. It's I think it is a good tool, but it's not something we can use or not something that is very useful for everybody, but is very nice for some people.
Okay,
Very,
thank you.
yeah, very interesting. Actually, the time is running very fast. We actually half an hour beyond our session. Dr. Yamashita, maybe we need to close this session.
Okay.
Yeah.
Thank you very much for all speakers, for chairman, and for all attendees. It was a very interesting meeting, so I have learned a lot of things in this session. Uh, uh, so we don't have much time to discuss about this session. So thank you for attending this meeting.
Thank you. Let's keep in
Thank you.
touch.
Yeah,
Thank you. Bye
thank you.
bye.
Yeah, bye.
Thank you. Bye
Thank you.
bye.